Here.
Oh, you are?
Yeah.
Oh, okay. I just don't want to see everybody, I guess. I wonder why I can't see everybody. Um, Show grid video. Okay. Huh. All right. It doesn't matter as long as everybody's here. Um, oh, there you are. All right. Anyway, so this is the focusing on shoes. It's not just injury prevention for the runner. Um, and so the shoe construction is basically where we'll start. And in fact, let me, we have video. Let me just grab a shoe real quick. So the general idea is even knowing what the shoe is made of. And then we'll go into all the controversy about footwear. The one thing about this that's an interesting point about this topic is it's a lot of discussion about how things haven't changed much. It's amazing. The technology has not been associated with a reduction in injury, performance, some controversial issues, especially the new Vaporfly from Nike, supposedly with the sub 2-hour marathon, and a very rigid bottom to that shoe, otherwise a relatively simple shoe. But so anyway, so the outsole, midsole, sock liner, and then you'll see all these 4 topics here. And so what we have here is the heel cup, all right, on top, and then the midsole. And the midsole is where you see a large amount of the breakdown. What you want to do in general is when you do have somebody with a lower extremity injury who's a runner, is you would like to have them ask them if they've tried a new shoe. Literally, all they end up with is a new shoe. And far more often than I thought would be true is their symptoms go down or go away because they get into a new shoe. At one point, I looked at 500 emails, and in those 500 emails, it seemed like half the time by having them change their shoes, their answers were solved. So shoes will break down when they're new. Shoes will break down when they're old. It just depends what happened off the line, if it's a defect or if it's shoe breakdown. The outsole is made out of, and this hasn't changed much. It's still hard rubber, not really a limiting factor in shoe breakdown. The midsole, it also hasn't changed in about 40 years either. If you read the book Shoe Dog by Phil Knight from Nike, basically what they did back then is what they're doing now. They use ethyl vinyl acetate. It's the foam in the middle here, right down here. And it is essentially the cushion. If you have grid, you have wave, gel, like or air, as in the Nike Air. This was not done by research. Phil Knight and some friends put on some Nike shoes from an innovator who said, try these shoes with air, and they liked it. So all these innovations basically still come down to ethyl vinyl acetate in the shoe with one of these little gimmicks inside of it. Polyurethane is a firm material to make the shoe harder, quote, stability, or less flexible. So the sock liner is the insert, and we'll talk about that. It's very flimsy, usually almost not much of anything going on inside the shoe with a sock liner. And I think everybody here on this talk probably knows what a sock liner is. Its function is questionable until you make it into an orthotic and you put something else in there that's a bit more supportive. So it's the sock liner that you're trying to modify whenever you are giving people orthotics. The upper is interesting because it's a key factor in shoe breakdown. The heel cup is above the bottom parts we mentioned, the outsole, the midsole, the sock liner. The heel cup is the first part of the upper section that we're going to mention. It should be snug to the heel, but allow for the heel to grow out. And we'll go over why that's true. Heel cups are a big source of injury, which we're going to show in some slides going forward. The throat is also a very interesting thing that has been underappreciated. When your runner's foot goes numb in the toes, very often it's the shoe logos that are a problem. And we'll go over that and how they're pinching either maybe on the posterior tibial nerve, the plantar nerves, or the circulation. Maybe it's just kind of choking off circulation to the front of the foot. So this midsection of the shoe can be an issue and an argument why shoes should be simpler. The vamp is that part where your toes are. It's nylon mesh material, a lot of logo designs on it, and then the toe box has to allow for room, especially for the great toe. The great toe really gets hit pretty hard in the toe box. The upper throat and the vamp may explain an awful lot of lateral foot pain that you think is peroneal tendon insertion pain, and often it's really the rubbing of the shoe on the lateral side. So here is the shoe construction. Here you have the logos. This is a seam ripper. So I found that a lot of my patients, when I ripped off their logo, they let me, and it didn't destroy the shoe. That by ripping off the logo, I took care of a lot of their problems: lateral foot pain, peroneal tendon pain. On the medial side, their great toe all of a sudden wouldn't hurt because now the front of the shoe opened up without being ripped apart. So these logos, for the most part, are decorations that actually get in the way. They don't have much of a functional purpose. If you rip off enough of them, I guess you could lose the lacing on top. So that could be a problem, but it's mostly an interference. And also this throat right over here. So this is the throat. And if this logo is trapping on the medial or the lateral side of the shoe, this logo will also can also cause the toes to go numb. You rip off the logo, the toes don't go numb anymore. Essentially, the shape of the shoe is called the last. And I think everybody here knows what the word last means. I'm going to guess in sports medicine. It's basically the shape of the bottom of the shoe. So this is the last right here, how the shoe looks on the bottom. And if it's curved, it's going to have a little bit more arc through it. This section here is going to be cut out, and that's called curved. And so we can determine what that all means. At first, let's realize what supination and pronation means. Supination is basically the foot is inverted, which leads to the tibial internal rotation, and we'll go over to the whole kinetic chain. But the subtalar motion is that with supination, the calcaneus is inverted, and then pronation, the calcaneus is everted, and in pronation, the forefoot goes into an abducted motion where you can see the toes. So the forefoot abducts as it pronates. The forefoot abducts. It adducts as it supinates. And you need both of these. And this becomes a very interesting thing in modifying what we assume to be associated with running injury. Is the overpronator, the oversupinator, they have different injury patterns and so on and so forth, and we're going to go over how that's not true. That they actually have more in common than they have not in common. So the supinator and the pronator both get injured in very similar injury patterns. And I want you to remember this pattern here. What you see is from here to here is basically a spring coiling and then uncoiling as you run. So it comes from here to here through mid stance, and then from mid stance to toe off, from pronation to supination, you uncoil your foot, and this has a very important spring effect. So here is the pronated foot. Now, there's an awful lot of things in the middle, so I wouldn't get too obsessed with seeing if this calcaneal inversion is more than 10 degrees. That starts to become important, called the extremely pronated foot or the flat foot. The flat foot, where the navicular drops down, is a problem and needs very typically needs support. Low arches versus kind of a higher arch, not so much. Now, this is a supinated foot, which is a super high arch, and this is where the navicular is basically buried inside the arch. And I like to use this as an indicator of whether or not that arch is high or not. Another thing you'll notice here with high arches that is understated, we all focus on the last or the shape of the foot on the bottom. The dome of the foot in a high arch foot catches a lot of trauma in shoes. So this is still how you determine a curved last versus a straight last, the pronator versus the supinator. And how do you measure this? You still do it this way: sand. all right? It hasn't done much, we haven't done much better. You can do footprints, you can do ink blots, but nothing like having a box of sand in your office, which I no longer do. We just look at it. But this is how you can best determine the shape of that foot and what kind of shoe last shape should be used. And we want to disconnect two things. A straight last like, whoops, a straight last like this one here versus a curvy last here, this does not require a high stability shoe any more than this foot does. And we're going to go over why that's true. So here you have the shoes and the shape of that last. And then one last thing is that in last, you'll see sometimes combination or slip lasted. Slip means simply that there's a stitching in the middle, there's no board in the bottom. Board lasting is that there is a board to give the shoe more stability. And so now let's go back to how things haven't changed much, and this is still true. So Cook in 1985 in the American Medical Journal of Sports Medicine was showing early on by repetitive loading of shoes that they would break down within 400 miles. So shock absorption would be 75%, already you would lose 25% of shock absorption within the first 50 miles of wearing a shoe. So right away, the shoe pretty much loses its shock absorption. And then less than 60%, somewhere between 250 and 500 miles. Also, the warning sign, if somebody has a feeling of pain in their legs or aching after buying a new pair of shoes, the shoe may be kaput right from the time you bought it. And this happens quite often. And we always joke about where it's made, but I don't know if I can joke about that anymore. Shock absorption in vivo is, when, in other words, having runners beat up their shoes and then doing that same Instron assessment shows that in life, we lose about 30% of the shock absorption by 500 miles. This has not changed since 1985. Pronated foot, pliable, leads to increased torsional stresses to the lower extremity. So for medial posting and support. This is still true when you want to try to support an overpronated foot that's just really excessively stuck in pronation. You can post it, you can push it up, you can support it up. A supinated foot, you cannot laterally post. You still will see this posted or in the literature. There's no way to make a stiff foot bend inward. Supinated feet are stuck in supination and stuck in inversion. So therefore, if you put a lateral support under the shoe or the foot, you drive the whole person in. You throw the whole person, the whole kinetic chain goes immediately thrown in. So what you do is you cushion up the arch and you can give a little more arch support that could actually unload the stress through some kind of resorbent material, shock absorbent material rather. So here we have the whole mechanism. This is wrong as far as external tibial torsion. This is an old Netter slide, but it's internal tibial torsion. At forefoot abduction, this is a big deal. When you're not so sure if somebody is overpronating, here's a couple telltale signs. One is when they stand on a single foot, does their arch drop? Two, does their foot fall out into abduction? So forefoot abduction is a telltale sign that this person has, if you will, a pathologically pronated foot, that it's going to be a problem because the foot is now falling outward versus just somebody with a little bit of a low or a high arch. So there's mechanically a way to see that it's a significantly low arch or not. Then you have the Q angle, typically anything, it used to be 20 degrees, but anything more than 11 degrees in guys, 15 in women about is considered an excessive Q angle and stress to the knee. And then you have the tibial torsion and the femoral neck anteversion. So in other words, if you put this foot into neutral, the trochanter is actually rotates forward, and that's called anteversion. So this is what happens with a shoe support. And this is why a lot of people say, look, see, I've corrected your positioning. What they don't point out is this foot no longer goes from supination to pronation. It's stuck in one position, and when it strikes the ground, it's in this position. And when it leaves the ground, it's in this position. So this shoe has actually done a disservice a little bit to the runner by eliminating the closed chain kinetics that are supposed to happen at foot strike. So it's not simply enough to have a stiff shoe hold you up. And that's why stiff shoes are actually a problem. They actually take away whatever it is you were trying to correct, they replace it with yet another problem called no shock absorption for now the wrong reason. You were trying to correct shock absorption, give them a lot of cushion in their shoe, but they don't move. It's a brick. So they looked at this back in the 1980s, and they showed they do a lot of military work. You know, the military does a lot of research, and in the special warfare unit, I loved it. 77% had some kind of injuries, but that's consistent. Runners actually up to 70-some% will actually have an injury of some sort. If you include pain that interferes with their running. Stress fractures were 13%. Lower extremity was actually, the tibia is more than the foot, and then the femur, not common. Both supinated and pronated feet had very similar stress fracture patterns. This has been known for over 30 years. The IT band, 11%, patellofemoral tracking, 9% Achilles tendonitis, 7% periosteitis. No association between foot type and knee overuse injuries. This is not news, but yet this keeps getting propagated, you know. I don't know, is Trump still talking? No, never, I won't do any Trump jokes. Injuries and hindfoot pronation injuries, 60% of injuries are due to training errors, too far, too fast, and that was determined in 1978. It still is true. Barry Bates and Stan James from Oregon State, from University of Oregon. Sorry for any Oregon people. University of Oregon. They were famous for the Nike Athletics West training team, training people like Joan Benoit and so on. So they had a large number of runners, and they were talented runners. So these were not necessarily runners that had just gotten off the couch. And so basically in pronated feet, there was a slight difference in that there was, in general, the posterior tibial syndrome was, interestingly, a little more common in the general population. The posterior tibial syndrome was 15%. And no, actually, so very little difference between these two. 15% plantar fasciitis was a few percentage points more than plantar fasciitis. The take-home point here is if you look at the distribution of injuries on the left versus right side, it's very hard to see a difference. It's really funny that there was more knee pain in the general population than there was in the pronated foot. Now I show this because it's wrong. This was in the running shoe in running medicine. And the reason I have to just do this is because you see this, you read this, you keep on promoting it, or we promote it, and it's just not true. So the high arch, rigid foot, tibial, femoral, tibial and femur stress fractures, the supposedly in the high arch foot, Achilles tendonitis, plantar fasciitis. In the overpronator, supposedly they get more medial tibial stress syndrome, more torsional pain, more patellofemoral pain, more popliteal tendonitis behind the knee, and more posterior tibial tendonitis. So I put this out there. This is actually not true from the previous slides, that somehow this got propagated in the face of literature that says this is not true. So why do people correct these two problems if neither one is getting more injured than the other? It's because here is the kicker. The high arch foot is stuck in supination. The pronating foot is stuck in pronation. What do they both have a problem with doing? They have a problem with going from supination to pronation to supination. So because they cannot go from supination to pronation to supination in the normal running cycle, they both have lost their shock absorption. Picture a spring stuck in full compression. A spring is now stuck fully compressed, or a spring that's stuck fully open. So the spring that's stuck fully open has no shock absorption, nor does the spring that's fully compressed. So the spring that's fully compressed and stuck in opening has loss of shock absorption, which the runner needs. So pronation control, here it is from Benno Nig back in 2001. Shoes are not great at shock absorption or pronation control. He put markers into the bones of runners. I don't know how he did that. but he had markers that were independent of the shoe, and he found that runners, their feet moved inside of their shoes. So the shoes look like they control movement. What they do is they interfere with movement. And so he has a thing about that we'll get into, but shoes interfere with the normal movement of the foot, in some kind of effort to try and not have the person overpronate, or to try and give that person more cushioning. So he really questioned the effect of straight versus curved last, heels flare, cushioning versus stability shoes. He questioned the whole business. I will override that, saying that we're going to go over to something called comfort. And so when the shoe fits the runner in the right shape of that foot, when the foot shape and the runner's foot are very similar, the runner perceives comfort. And we're going to go over that. So comfort is actually going to be a huge thing here. Steve Robbins found impact loading not reduced by cushion or pronation control. So none of these mechanisms in these shoes that were intended to cause some kind of change in impact loading have any effect at all. Running injuries were 123% higher with expensive running shoes versus barefoot or less expensive shoes. No differences in injury rates with high, medium, or low impact style running, meaning when the foot strikes the ground, what is the maximum impact at ground strike? It doesn't mean that slamming the ground is good for you. It's saying that at maximum load, after your foot fully lands, the maximum load point, some are high, some are low, at the total impact and that is not an indicator of running injury. Tendons and ligaments are the biggest reason for shock absorption, and midsoles and outsoles lose half the shock absorption that you normally would have. They actually take away half the shock absorption. That was known in 1997. So barefoot running, that's my kitty on the left side there. So that's our cat. And so she's been barefoot and she has her claws. So, and she never had any foot injuries. So there's proof right there. But barefoot, did I lose something? Oh, shoot. Okay. This is considered barefoot running, even though some people would call it minimalist. So when you wear a Vibram five-fingered shoes, you'll see that studies will consider this acceptable as a type of barefoot running, just to be clear. This is one of the first minimalist shoes I saw on the market, and these would be minimalist shoes too. I'm going to use the Timothy Noakes method for looking at minimalist versus regular what we'll call shod. So this shod shoe has no bend in it. So you twist the shoe. This is a Timothy Noakes system for seeing if a shoe has any kind of give. And this has no give. It has plastic on the bottom. So this is why I'm just such an old crotch about plastic on the bottom of shoes. This bends, it crunches, and it goes either way. So this is considered flexible or a more minimal shoe. It also has very little, we're going to go over what minimal means, but it has very little drop also. So, minimalist running shoes. So this is what Ricks has proposed as the definition of minimalist running shoe. He cited it from somebody else, so we'll accept this as the definition for a minimalist running shoe. Footwear that weighs less than 8 ounces, very light. Okay, like this one. Heel toe to drop less than 5 millimeters. No special effort at cushioning or padding the shoe. Anything else is called shod. All right. Bibi Bikila in 1960 proved that with no shoes at all, you can win the Olympic marathon. Took a little more than that to win the marathon, but he didn't let shoes get in his way, and he was extremely successful without any shoes at all. Now, are you Bibi Bikila? And that's always the next question. But this is called the initial transient force transient. I didn't even know this. I just discovered this recently, but this transient, I used to call it just a force spike. This initial force transient, in case you ever see this pop up somewhere, is the mark of a heel striker. All right, so this is 4 foot proponents. I'll tell you why I'm not all that big on the forefoot strike. I think it's a distraction to what you're trying to accomplish with a runner. But this forced transient is considered not good. It's an impact spike. When you are barefoot, this forced transient is replaced by just a very smooth curve. And so you have this no forced transient as the forefoot strikes, and then as it toes off, here you go. So anyway, onto the other foot. Notice something here called the toe, heel, toe. Even if you are a forefoot striker, you're still going to strike your heel, or you should. Okay. Now there are some forefoot strikers that are real ballerinas, or whatever, but the heel should actually at mid stance land, and then the heel should come off. So there's heel strike is still a part of forefoot striking, just so we have an understanding on the mechanism of that. This is all part of the cushion, right? So you see the spring mechanism by the fact that you do this. If all you did was keep your heel up in the air and you didn't do this, you've lost some of your desired spring effect. So now barefoot running. Okay, so Lieberman really started becoming one of the more famous people in the journal Nature, showing that runners have been running for millions of years, and so running shoes only around for the last 50 years, if that. And then some previous versions of slippers that were called running shoes in the earlier part of the 20th and 19th centuries. This is, it's an interesting argument. When I had an ophthalmologist once tell me, yeah, but we've been around for millions of years without glasses and we still need them. So there's a compromise somewhere where shoes are necessary. And he looked at runners, basically the bottom line is he took Kenyans, he put shoes on them. He took Americans with shoes and took off their shoes. And then he had some adolescent Kenyans who ran with shoes and barefoot. What basically he found was that by simply taking off somebody's shoe doesn't make them a forefoot striker. And if you were a forefoot striker, putting on a shoe doesn't make you a heel foot striker. So there's a huge amount of habit that's involved in this forefoot and heel foot striking issue. So simply taking off the shoes is not enough to do it. Although I'll personally tell you, from even having gone barefoot for a period of time just to have some fun with it, if any of you have run barefoot for a little while, you'll notice that you really don't like heel striking for very long. So you definitely start coming off your heel a lot faster. So a colleague, Casey Kerrigan, she looked at 68 subjects. The only thing I don't like is they all wore the same exact shoe. That I always find that a little tough. And in looking at the ground reaction forces, the shoe versus without the shoe, their impact forces were 36% were increased. The ground reaction force, excuse me, especially in the knees. They were all increased ground reaction forces, and then the angle of flexion also was greater in people wearing shoes. Also greater varus and greater internal rotation of the whole lower extremity. And then we have the minimalist running counterpart. If you take a bunch of people who have been wearing shoes, and they've been wearing Nike Pegasus, or some other similar shod shoe, and then you switch them to Nike Freeze, or you put them into the Vibram 5-finger shoes, actually, by switching them, the ones that were in total barefoot or at Vibram 5-fingers had 23 injuries. These were similar numbers, by the way. And then the ones that were partially minimal shoes had 12 injuries, and the ones with standard shoes who were never switched had the fewest injuries. So switching, in other words, the moral of the story is switching a person out of a standard shoe and simply putting them into minimal or barefoot situation is a great way to get them injured. So you have to really be very careful. So there's actually proof of that. Calf and shin pain was the most common complaint in the minimalists. They didn't get knee, they didn't get or hip or other pain from these minimal standards. Minimal running injuries, the type of injuries in minimal runners were, so far this is a case series, but I haven't really found injury publications that say knee injuries or femoral neck stress fractures or tibial stress fractures or compartment syndromes are coming up with the minimal shoe injuries. It's really a lot of metatarsal stress fractures. That's the lion's share of what you see, is metatarsal stress fractures, and then there was a calcaneus stress fracture in this case, and a plantar fascial rupture. And this is my own personal clinical experience with people who are coming in minimal shoes and barefoot shoes. Foot orthoses will actually help an injured runner. The controversy of using orthotics for injuries, there's controversy of that. Like, should you put an orthotic into a running shoe to prevent a running injury? And that's very controversial. But once a runner is injured, the weight of evidence is that a well-fit orthotic will help with the resolution of that injury. And the reason for that, though, is the thing that's mysterious. It's not through pronation control. It's not through supination control. It's through something that they believe simply reduces the muscle activation in weight bearing. They do see this. When you put a comfortable orthosis into a shoe and the patient now has comfort in that shoe, they contract their muscles less. So soft insoles, it turns out, Ben O'Nig then found this out just recently in 2015, I want to say. In soft insoles, I didn't put in the data of that, sorry about that. Soft insoles are associated with fewer injuries than hard insoles in military shoes. And so this is just in the last 5 years. He found a name for this called the comfort filter. We always were saying, well, if a runner's comfortable, that's the best thing to get them for a running shoe. Whatever gives them the greatest comfort. Well, there's a word for it now, comfort filter. So picking among 6 insoles, the ones that were picked for comfort, the runner literally chose what insole felt best, had 53% fewer injuries in military recruits who actually were allowed to pick their insoles. And comfort actually reduced injury, objectively reduced injury. So the use of comfort is an injury reducer. The preferred movement path is a fancy way of saying, what is the knee, ankle, foot, and running path of a barefoot runner? Are they running wide base, narrow base, their foot strike pattern? You want a shoe that interferes as little as possible with their barefoot running pattern. Hence, I will watch runners run barefoot a lot in the clinic, and then we try to give them as little shoe as possible that will do as little interference with their chosen path of running. But the comfort thing is the biggest deal here, is that there's actually objective evidence that use of comfort, not pronation control, not supination control, simply comfort. Okay, then improved footwear comfort reduces oxygen consumption during running. So it turns out comfort reduces the energy expenditure of a runner at a given pace. So using comfort makes them faster. It sounds like logic, but they actually showed oxygen consumption goes down. So fitting for these orthoses. Some people will have you stand. That basically all it does is crush the foam. So I wouldn't do that. I would say sitting. And then you can actually plaster mold the foot, get the actual shape of the foot. But then the key is then to make a soft insert that will deform to the foot over time. So instead of trying to capture the perfect foot in a foot orthosis, you use a soft insert. And the military studies are showing soft inserts, especially ones with greatest comfort, are going to be far more effective in the long run than these hard, rigid plastic things. You know, I'm keep on looking at the screen to see if anybody's still listening. But so this is posting. So this is what we call posting, by the way. So if anybody wants to know the word posting, that's what it means. You're actually moving up the entire foot orthosis or a major part of it when you say you post. So orthotics. These are over-the-counter orthotics. And These are over-the-counter orthotics. These ones are a favorite of ours just because we've had the most success with runners liking them. They have a key element here. They have a metatarsal support to take off shock off the front of the foot. They're soft. They have a deforming quality to them. So these over-the-counters for $50 instead of $500, many of our patients, when we tell them $50 versus $500, will gamble on the $50 orthotics first. And custom versus over-the-counter is still very controversial as to which one does the most injury prevention. So here we go. This is also from the previous study, Ben O'Nigg's article there, showing that injuries per 1,000 kilometers, there's very little difference in injury rate. If anything, the slightly pronated foot between 7 to 10 degrees of calcaneal eversion at stance, all right? This slightly pronated foot, if anything, is the winner. The highly supinated foot, a little more injury. The flat foot, the one with completely grounded foot where the navicular is on the ground, is the one that seems to catch the greatest lion's shares of injuries. So there is some evidence that if you are completely flat-footed, you get into trouble. So now we have this crossover design, which you looked at 168 runners with shoes versus barefoot. Men, 20 to 50 years old, mileage a bit variable, 15 to 50 miles per week, training, experienced runners. These are the various, I just listed all the different shoes they used. So what they would call a shod would be like the ASICS Gel Cumulus would be an example of a shod foot. The minimalists were like the Nike Mayfly, the Merrell Trail Glove, basically the Merrell Glove shoes and the Vibram shoes, and the Nike Free. And they didn't really care about their landing foot pattern. They let them heel strike, foot strike. And so it turns out running economy was best in the barefoot and the minimal situations. And both were better in using less oxygen uptake than the heavier shoes. So in other words, it costs less energy to run with light shoes. That seems common sense, but yet people are still choosing a heavy shoe. And I suspect that because the lighter shoes are not giving them comfort. They don't have the right shape. The shoe company is not giving them the shape of their foot in a lighter shoe. So they go to whatever shoe it is that feels good. Now, it comes at a price though. So when somebody picks a comfortable shoe that's heavier than a lighter shoe, if a lighter shoe had been available, is actually going to slow down, is going to use more energy. And rear foot, now, and this is a kind of a jab right here at worrying about rear foot versus forefoot strike. There's no difference in running economy. And there's more than one article, but I grabbed this one because it was a pretty decent one. So there's basically no difference in running economy if you're rear foot or your forefoot. So let's go over, so we're going to quickly go through all the other shoe injuries shoe-related injuries that go on. What happens with shock absorption loss is more importantly what happens with the shoe. The shoe falls apart. So people talk so much about shock absorption. Why does your shoe suddenly feel bad? And it's not the loss of shock absorption. It's this. It's the fish mouth or the breakdown in the heel. Whoops, sorry. So the heel falls apart, and now the heel cup rather falls apart, and you have injury of the striking part of the heel now no longer in a cup situation. Furthermore, why is this any worse than barefoot? Because notice how if you were barefoot, your foot would land in one position and then roll over. It would kind of go for, it would actually kind of roll out to in and back out, and you wouldn't spend all that much time probably on the heel. But when you're in a shoe, you strike the ground, you're stuck in this heel, you don't move much, your shoe breaks down, and you get an injury. This is why I kind of really submit to you that this plantar fasciitis is not what the board answer is. The board answer is there's a windlass effect. So when your patient comes into your office and walks on their toes and causes heel pain, it must be plantar fasciitis. Answer that question that way. The the opposite's true, though. The opposite is true. That when your runner can walk on their toes and has no heel pain, but they walk on their heel and have heel pain, it's probably the plantar fascia. Because what it is, plantar fasciitis, basically, what are we talking about? This injury right here. We're not talking about a mid-plantar fascia injury, are we? We're not injuring in the middle somewhere here. We're injuring at the enthesis. So basically, the plantar fasciitis is an enthesopathy versus calcaneal stress fracture component with bone marrow edema here. So it's basically a shoe-related injury or a bad heel striking related injury. And it's interesting, one of those barefoot injuries or minimal injuries was a rupture of the plantar fascia. So if you have a super high load injury to the plantar fascia, that's another game altogether. But this plantar fasciitis that you see in the office is a heel strike injury or a shoe defect related injury. So this is what you learn, win-loss effect. And what we try to do in the rehab, we'll go over this, is basically you try to do a lot of intrinsic foot muscle strengthening. Hence, one argument for minimal or barefoot training is to make the foot a lot stronger underneath this plantar fascia. And push out. And then when we go into push off, something else happens too. When you actually have an uncomfortable foot and you have a lot of strain in the foot, at least partly related to bad shoe fit, you start getting shin splints. And you get shin splints because the tendons reach up into the shin. And I think this illustrative science doesn't need a whole big diatribe on that, but deep posterior compartment syndromes and pain and periostitis and things like that very often are related to overstress to the arch or some forcing of stress to the middle of the foot, quite often from either a suprapronated foot being not supported or the arch under a lot of stress. So now another injury that happens is you see this and they get what? Proliferative therapy, they get percutaneous tenotomies. You use the, what's that new device now? The 10X, is that right? Okay, yep, the 10X.
Next.
Okay, so the 10X will try to get rid of this. Here's the problem, is it's not solving the problem. I'll do it too. If somebody has a lot of calcification in here and you're trying to get rid of the calcification that is formed, I understand that. And you're trying to go after this. So people will say this is an overuse running injury. It's actually this. You heel cups trying to change the shape of the shoe, which was always killing the runner in the first place. So you'll very often see that actually this was not the runner's fault. It was the shoe destroying the runner's heel. And you'll see these breakdowns. And so that pump bump that you're seeing is rubbing of the shoe, sliding heel cup, bad fitting heel cup, things like that. So the problem must be solved completely starting with the shoe. And then now we have Achilles lip or a channel for the Achilles tendon. So that's one solution. And then this is what I'll do in the office. This is just a little practical tip. I'll cut a wedge into the back of the heel and see if the runner feels a little better. I ask their permission, of course, before they do that, because shoes cost $120 and then you cut their shoe. So far, if I get their permission, they're never upset. Notice also in this one particular shoe, what do you see here? Breakdown. So again, you see breakdown. So whenever you see breakdown like this, basically the runner's foot pain is because it's been externally injured. And also it's interesting. So you'll get images, you'll get an x-ray, you'll get an MRI, which I'll do. But if you don't find the reason is because the reason was external or a training program. Now this is the Salcone Convara, one of the first minimal shoes out there. They've changed it. It's not minimal anymore, I don't think. But they have an Achilles tendon channel in here. I always thought that was kind of cool. The anterior compartment. Okay, do we see this here where the laces? Okay, now what kind of stretch is being done here to this foot? What tendons is this person stretching right now? I'll ask Marcin. Well, just in general, what kind of tendons is your voice on?
Can you hear me now?
Yeah.
Okay, so I don't know if that foot on top is the right foot is on top of the left foot. Is it?
Correct. You are correct. And she's stretching the right foot. I'll give that to you. Where her hand is stretching the foot.
Okay. So it looks like she's stretching the anterior muscles of the calf, right?
That is correct. And so these laces are actually trapping the anterior tendons. And they're trapping these tendons. And so you get an anterior shin splints. So this goes into something that I'm, this is a mistake that I never published. Not a bad mistake. I made a mistake in not publishing this. I was doing free care at a health club for 4 years of my career in front of Spalding Rehab Hospital. And I was just trying to help runners and then maybe take care of them in the office, so I relaced their shoes. So I would lace their shoes down, lower, or stagger their laces and take the stress off these high-laced running shoes, which is still the case, by the way. And I would lower the lacing down to here. And so all their shin splints, I got no patients from it because their shin splints went away. So this is when I first learned that basically this is a creation of our own doing. All right? That we are, or the shoe companies really don't have this down. And they're trapping the compartments. You're doing compartment pressure readings and things like that. And that's still indicated, that's still good and all good. But it's shoe created until proven otherwise. When you do have proof that it's not the shoe and it's something else like overuse injury, training program, shoe type, foot type, things like that, I get it. So here we have this entrapment of this shin, and you get a shoe-induced compartment syndrome or periostitis. You get shoe-induced periostitis. All these syndromes, therefore, first and foremost, you have to criticize the shoe and make sure that's not it. And so here we have an enthesopathy at the very top of the tibialis tendon insertion. And this is one of my little, my arrow misses it, but this is like a pad into the shoe tongue. So pad the shoe tongue, stagger the laces, play all kinds of games, different kind of shoe. And this is where also I'll submit to you, people with high arches have high domed feet. High domed feet very often get trapped on the top of the shoe. Okay, so now we have the bunion. So going into the final category of shoe injuries is the front of the shoe. And the front of the shoe causes entrapment and really wreaks havoc into the great toe. And so this shoe box is now finally being recognized, such as the Ultras. I think Tony Post has a bigger front of the shoe. And so these shoe companies are starting to just recognize that we want a wide forefoot. Some people say it's too wide, so they go the other extreme. But now the idea of the wide forefoot in almost anybody, not just pronators, but anybody with a V-shaped foot especially needs a wide forefoot. And so when you see this hallux valgus, it's been known for a long time, for over 20 years, by Coughlin and Thompson, that hallux valgus is almost exclusively in shoe-wearing societies. And then this Chinese study by Lam Simfuk and Hodgson showed shoe-wearing population in China. Again, those are the people who had the hallux valgus. Fashionable shoes. Again, this is where you got your hallux valgus. So we created hallux valgus for the most part. For the vast majority of these patients, we send them for surgery and things like that. Basically, it's self-inflicted. And so it just makes a very moral question when you send them for surgery and things like that. What are we correcting and when the problem's still there? So non-operative foot care versus surgical foot care. Bunionectomies related surgery in the female runners. And runner, basically it's not corrected, but a runner must be willing to trade relief of pain for a lower ability to run. Significant problem is professional sports and dancers. They rely on their feet. So until a person can no longer perform their chosen field, we don't do the bunion surgery. So it's a consensus by foot and ankle surgeons that I'm going to do a bunionectomy, but your chances for going back may even be worse for the surgery, even though we may give you pain relief. Some people go back, and some people do go back. The ones who do go back are quite happy. The ones who don't go back are patients forever, and that's what scares me. So here's a bunionectomy. Typically involves, there's multiple versions of the surgery, therefore suggesting that no one surgical solution is the answer. Basically a break of the metatarsal bone, the first metatarsal bone, and realignment of that to make this, to take off this metatarsal adduction, make it more abducted, and therefore the hallux valgus doesn't look so valgus. Notice that the whole foot now geometry is going to be different on this side than the other side. And I used to do this, and so, and it, you know, I realized that, you know, it's a little bit of stress on the second toe. So a patient came in with these. I didn't, they did. And so this patient-directed yoga toes that you wear kind of at night, and I've given this away as a birthday present to a relative, and they liked it. But my patients seem to like this. So it spaces all the toes evenly, and they buy these yoga toes. And if they have hallux valgus, it starts helping to reduce this toe. And in the office, I think Janelle's seen me. Have you seen me reduce a toe yet? A great toe?
I don't think so, no.
Really? Okay, that's right. Because all right, you will. All right, given the situations we're in. But I will reduce the great toe, and they get a lot of relief from it. And there's a way to do it. All right. So anyway, then you can also use hat pads that will also unpad the forefoot. I was mentioning the padding. So a metatarsal pad is a very big ingredient in soft inserts, over-the-counter inserts, and then also stretching the great toe, stretching the flexor hallucis longus is also a big deal. So this is a stretch that's never shown, and I would like to really promote this stretch. It's a very simple stretch. Grab the arch and stretch the great toe. Now, the next thing about helping to fight off hallux valgus, plantar fasciitis, and any number of problems. Notice how navicular stress fractures are not showing up as a minimalist or a barefoot problem. I don't know if has anybody seen a minimalist or a barefoot navicular stress fracture? All right. I don't know if they happen. So there's a lot of, even though we talk about metatarsal stress fractures, this is your vulnerable side here. In people that are not really ready for barefoot running, even though metatarsal stress fractures are your worst injury with a barefoot runner, they basically are spared a lot of these other injuries around here. So this is a shod runner, but basically the shod runner is strengthening their intrinsic foot muscles. So if they're barefoot doing this, this is a great way to get at something we now call the foot core, strengthening the core of the foot, and then getting them prepared for running. I will also have them run barefoot 50 feet times 7 times because nobody gets injured doing that. So some people say, oh, you can't have them run. Well, you can have them run 50 feet in their living room or hallway back and forth. And then addressing both the long and the long arch and the transverse arch. And so this is what I'll do with runners, is I will let them put on their own tape. I will show them how to do it once, and then I'm going to say, tape your own shoe. And when they tape their own shoe, they come back and say, this is what I like. And this helps the orthotics maker. It helps them. It helps me. It tells us what kind of correction they actually need. So runners who are, especially the experienced ones, will, if allowed, create their own orthotic. And then, of course, their daily footwear is a big deal. I'm not thrilled about this. This is a Rockport. It tends to be wider. But one thing you have to do right off the bat is try to convince them to wear Keens, the bigger Echoes, some of the more custom, Kenneth Cole shoes, things that will allow some fashion look to happen, like Fluvog for women allows a wide forefoot or even an open toe look. And this may be healthier for their daily footwear, especially if they're athletic. And then finally, if you have this kind of foot and you're trying to correct it with footwear, where you have plantar fasciitis, flexor hallucis longus tendonitis, deltoid ligament strain, peroneal tenosynovitis, all in the same runner on the same MRI. And you tell me, how many MRIs do you see in runners with only 1 or 2 lines on the MRI diagnosis? And that would be a publication right there for a fellow. I think that's a good one. That's a good one for fellows and residents, is take 100 MRI readings of injured runners and report how many injuries are reported on the MRI versus the patient's symptoms. That's all. Look at the MRI. What were the runner's symptoms at presentation when they come into your office, and what do you see? So typically the MRI will look like hell. And you see an awful lot of these minimal injuries, not hell, but a lot of these mild injuries. So basically what it does support is runners are beat up. And so because it's so hard to make a runner feel good, it's because in fact they are beat up. They probably do have 2 or 3 diagnoses all at the same time. This one has a navicular stress fracture, enthesopathies, and outright synovitis in this one runner, all right? Completely, this is when it really took a toll. So you have to really have them have water immersion, get the whole foot chilled. And this is why I start resorting to these things. So when runners just have foot pain that you can't figure out, and it just hurts, and you maybe gave them an injection too, you gave them physical therapy and they hurt, I submit to you, just put on, have them custom molded to a plastic AFO, or have them put on this walking boot. I have a hard time with walking boots because I can't control the foot inside. Unless you put an arch in support, you can put an arch support inside. So you put an arch support inside, or you have this plastic AFO. And with either of these, you rest the foot, even though they're weight bearing, for about 8 to 12 weeks, kind of like plantar fasciitis, and you just have them chill, cross training with running or bicycling. And then we get into the whole issue of getting back the whole lower extremity kinetics again, the iliopatellar band right here, or the retinaculum that comes off the IT band to the patella causing knee pain, because they were overpronating or just poor shock absorption from a supinator and from a supinator and pronator, and they strained their knee. So now the way you start unstraining the knees, you've got to get them back in line. All right, so here's a nice simple way to get them back in line. I put them on a balance ball. More importantly, I put them more in this green thing because this is dangerous without supervision to have them on a BOSU ball at home and have them fall flat on their, whatever. And falling off a BOSU ball is not fun. So we have them on a balance pad, and when they start balancing, they start lining themselves up automatically. And they start taking care of their chondromalacia by doing this. And another way to take care of chondromalacia is to have them have a nice 4-foot kick run where their whole leg comes out and finishes the stride instead of running bent kneed. These are really excellent runners. This is the mark of an excellent runner, is they go into almost complete knee extension before they hit the ground. So that's why I don't stress rear foot versus forefoot. By far the clearest, most important thing is to get full knee extension and then start pulling as you hit the ground. So this whole nice, beautiful, lined up closed chain kinetics. So, and then here we have this. Is your runner a runner? Does anybody see a runner in this crowd? Do you see runner, Jay, or Marcin, or Poonam? I don't know if she's still on, or Carrie. Anybody see a runner in this group?
I do not.
Okay, so nobody sees a runner, I take it, because none of them are running. This is 11 minutes per mile. I elected to walk in the Chicago half marathon. I also walked in some 5Ks, accidentally beat 80% of the hot chocolate 5K runners by walking in it. That was a little shocker. And then the other shocker was in the half marathon, I went to the very back of the race, which took almost 50 minutes to start the race. That's the other thing that surprised me, is there's a complete time to go to the bathroom, park your car, and still line up for a race these days after the gun has gone off, if you go to the back of the race. And so it took me 50 minutes for us to even start. And when I started walking, I thought I'm going to walk among the runners. Well, at 11 minutes per mile, I actually found that at least 30% of the half marathon, I'm going to submit more than maybe half of the marathon at the Chicago Marathon doesn't run. So when you rehabilitate these people, realize that you're talking about 4-foot striking pattern. It's not even a conversation for at least 30% of your runners, depending on their speed. So these people are walking. In other words, they never left a heel-toe striking pattern, ever. So they have them 4-foot run makes them do nothing but walk on their toes. They're not running. So at least 30% of the running population, I should say, at least 30% of the running population in the recreational world doesn't even care about 4-foot strength. And this person does. So Nancy Rollins, at 60 years old, ran 3:30, and she still ran 3 hours and 40 minutes during the heat wave at the 2008 Chicago Marathon. This is her finishing in 2008 during the heat wave. And she's happy until she found out that she wasn't going to get an award. So 2008, they had called off the race by the time she crossed the finish line. So even though she won her age group in 2008, in that hot weather, she didn't get an award. So whatever. Running times, 60 years old. She qualified for the Olympic trials at age 54 when the qualifying time was 2 hours and 50 minutes. So if you do it right, and you get this all correct, distance running actually can be pretty good, but it's a dangerous endeavor for sure. But when you get it right, really nice results happen. So that's and now we already know that Ted Whitlock did a sub 3-hour marathon at age 70. And so amazing things actually will happen with these people. That's it. So any questions?
What are the names of your cats?
Yeah. Okay, on the left, this here is Honey. We call her Miel, the Spanish name Miel.
Okay.
And then on the left, and the right here is Miss Purdy, because we were watching The Nutty Professor when we first got her. And sure enough, his girlfriend was Miss Purdy. We just thought it was the best. And I can't say enough about Siamese cats. So you don't want to start me. I mean, they're just heaven, absolute heaven. But you have to pay attention to them. They like attention, a lot of it, and they will talk.
Good to know. Good to know.
So, all right. Thanks for this group. I hope it's worth recording. Does it work out on the recording there, I think?
It still shows like it's recording. Carrie, you can stop the recording at any point.